Hi, good morning, everyone. Thank you for joining us in this health and wellbeing themed parallel session. My name is Michelle Morris, and I'm a co-investigator at the CDRC and an associate professor in nutrition and lifestyle analytics at the University of Leeds and a fellow of the Alan Turing Institute. It's my pleasure to be chairing this session today. Health and wellbeing is one of our key research themes at the CDRC. There are a number of factors that affect the health and wellbeing of individuals and communities. These include, but are not limited to, where we live, the environment we reside and move within, our genetics, household income, educational level, and the way we interact with those around us. We can learn more about many of these factors using consumer data. Sources of consumer data are wide ranging, from survey data through supermarket transactions, smart card swipes, and data from apps, which can all really reveal important behavioural insights. Many drivers of health and well-being are complex and multifaceted. The inherent interdisciplinarity of consumer data research, combined with data science methods, allows us to begin to unpack some of this complexity. Given the interdisciplinarity I describe, you may not be surprised to hear in our talks today that aspects overlap with other CDRC themes. Diet-related ill health, such as obesity, climate change, and an ageing population are some of the biggest challenges our society currently faces. Today we will hear from 4 CDRC colleagues about their research using consumer data to better understand aspects of these challenges. These talks not only include examples of novel consumer data and research, but how these can be combined with more traditional survey data to carry out impactful research for societal gain. We will hear our 4 speakers in succession and then have 15 minutes for questions to all the speakers at the end in a panel session format. Please do post your questions for our speakers in the chat throughout the talks, or make a note of them and save them up for the end. If you want to kind of upvote a question, give it a thumbs up in the chat and we'll try and prioritise them using that. So without further ado, I will now hand over to our first speaker today, Dr. William James.
Thank you very much, Michelle. Hopefully everyone can see the slides okay there. So today I'm going to be talking about using national surveys to understand diet patterns for health and sustainability. So my research is based on this idea that socio-demographics and food consumption are really tightly linked. So some food items are specifically designed for certain populations, so baby food, for example. We've got other examples where the products are restricted to certain groups, such as alcohol. We've got some often religious and cultural restrictions. So certain populations are very unlikely to be eating pork, for example. And there's also a strong element of affluence and affordability. So the sorts of people who are eating 125 grams of caviar for £300 are very different to the sorts of people who are eating value pasta. Finally, we've got this idea of the sort of generational and habitual consumption. So I'm sure we've all heard of the avocado generation or the latte generation. So studying food consumption and the socio-demographics is really important because it links into a lot of the sort of the really big challenges we're facing at the moment. So on the broad scale, we know that around 70% of all deaths are caused by non-communicable diseases, where diet is a key modifiable risk factor. From the environment side, we know that food production accounts for about 1/3 of all greenhouse gas emissions, and also that non-vegetarian diets have emissions of about 60% higher than their vegetarian counterparts. So there's real scope here to actually tackle some of these issues. This can mainly be done through what we call the targeting of resources and policy interventions. So this might be targeting specific age groups for health screening. So if we think of maybe targeting elder males for bowel cancer, for example, it might be through the regulation and reformulation, so lower salt, lower sugar foods. It might be advertising control. So we've just seen recently that the UK's adopted a junk food TV adverts ban before 9 o'clock to try and stop younger children seeing these adverts for high sugar, high salt foods, for example. We've also got fiscal measures, so looking at alcohol taxing, possibly meat taxing, and then the more normal sort of public information campaigns, so social media or the more traditional sort of billboards and flyers, that sort of thing. So most of the data that I use comes from the National Diet and Nutrition Survey, and this is a nationally representative survey of about 1,400 individuals each year, and there's currently 9 years worth of data available. And this provides us with detailed consumption estimates of food and drink products. And this is not just the products, but also the disaggregation of composite dishes. So if someone's consumes a portion of a lasagna, it gives an estimate of how much of that is meat and how much is vegetables, for example. And this approach also allows for estimates of the nutrient intake for each individual in the survey. And importantly, also the survey also includes socio-demographic variables for each individual. One of the things that it can't do in its raw format is look at the geographical variation. So this is sort of one of the first bits that I'm going to talk about, how we can get from this non-geographical raw data set to actually look at local level estimates of consumption to see how consumption in a specific area of Leeds, for example, might compare to an area in London or anywhere else across the UK. After that, I'm going to go and talk a little bit more about the piece of work that I'm involved with now, which is more about these targeted policy interventions and some of the conflicts and trade-offs that might occur with this sort of approach. So to start off with the spatial microsimulation for looking at these small area estimates, I'm not going to go into the technical detail here, but what we're basically doing is using the raw data from the National Diet and Nutrition Survey and reweighting that against the spatially aggregated data sets we do have from the census or the annual population survey or something like that. And what this allows us to do is to create this synthetic population and to get these local area estimates. And in my case, I use the R programming language for this. So the initial data from the National Diet and Nutrition Survey is really good at looking at the profiles of food consumption for each different product by socio-demographic groups. So here we've got 4 examples here. And so for alcohol, for example, you can see that, as we'd expect, we've got very, very low consumption with younger age groups rising, and we can see the male-female split there, and then declining a bit with the older age groups. Bacon and ham is slightly different because we've got a bit more consumption with the younger age groups. Obviously, portion size is a bit of a controlling factor here, seeing the rise, and then it sort of plateaus off again with the male-female split. Burgers, we see much more of a peak in the sort of in the teenagers, early 20s group, before it really tails off down in the older age groups. And then it's quite different for game birds, where we see a gradual rise and higher consumption with the older age groups. And we can do a similar thing if we're looking at disaggregating by ethnicity as well. So as we might expect for these examples, people of white ethnicity consume a lot more alcohol, bacon and ham. Poultry, on the other hand, we don't see this. Perhaps this is because any groups which don't eat bacon and ham for cultural reasons, they actually substitute this as poultry. Perhaps this is why we're seeing slightly almost opposite trend there. And then what we can do, because the National Diet and Nutrition Survey has these socio-demographic variables, and we can also have these same variables from the census or other surveys where we know the geographical distribution. So just a couple of examples here of the Leeds and Bradford area, so you might recognise some of these places here. And we can look at the age structure or the ethnicity structure for different groups and see how that varies spatially. So you can see that the elder populations are clustered in certain areas, and also different ethnicities tend to cluster in different areas as well. And what we can do is we can merge these two together, reweight the dietary data according to these, and we end up with something like this. So if we run the microsimulation for alcohol, we can clearly see there the yellow areas is where we've got the really high consumption in the sort of student young person corridor, and then the lower consumption in the more ethnically diverse areas. And then the same with bacon and ham, we see the low consumption in these ethnically diverse areas, but we don't see the sort of student corridor. And this might be because we're seeing more of a sort of habitual consumption, more people environmentally aware in this area who are more likely to be vegetarian, for example. But this is all sort of the interpretation of the maps which will come after this. So this is how we can use the link between social demographics and food consumption to really geographically target the consumption, any policy interventions we want to make. So another piece of work that I'm working on at the moment is looking at specifically one of these policies and seeing what would actually happen if everyone abided by it, and looking at some of the conflicts and trade-offs that might occur. So what we're looking at is the NHS and the World Cancer Research Fund guidelines for red meat consumption, which broadly say they want that everyone should limit their red meat consumption to about 500 grams a week. And of that, very little, if any, of that consumption should be processed red meat. And later on, I'll say why this is such an important distinction here and what difference this makes. So again, the National Diet and Nutrition Survey can be used to see where any policy intervention should be focused. So we can see it should be with the males of the age groups where the consumption is highest there. And as part of my work, what we're able to do is actually synthetically modify the diets which are contained in the survey data and investigate the secondary impacts. So looking at what would happen to people's nutrient intakes, what would happen in terms of the greenhouse gas emissions, and what would happen in the overall consumption and the impacts on the workforce and the actual industry, the meat industry itself. Here we're just taking away the products, so this actually helps us see which products would be best to replace them if people were taking away red meat. What would be most beneficial to replace it? Would it be with poultry? Would it be with meat-free substitutes, for example? So if we just take a look at nutrient intake as an example, so we can see what nutrient intakes were prior to the intervention and then after the intervention. What we find is that the adherence, obviously, because we're reducing intake, the number of people failing to reach the recommended intakes actually increases. So for females failing to achieve their recommended iron intake, this increases from 22% to 27%. And similarly with males, we see here quite a large increase in the zinc intake. So the people failing to meet that goes from 7% to 17.9%. There's much less impact on the number of people reaching the limits for vitamin B12 and vitamin B3. So this kind of suggests that any substitute products should be focusing on the iron and zinc rather than the vitamins there. Another impact here we might have is looking at the emissions and in terms of climate change. And the first thing we found out was that if everyone adhered to the regulations suggested there, that the overall consumption would reduce by 59%. Now, slightly counterintuitively, the emissions are only reduced by 43%. And this caused a little bit of a headache start to sort of try and pick apart what's happening here. But this is actually driven by the fact that we've got very different guidelines for processed red meat and non-processed red meat. So in terms of the specific guidelines, it actually really is focusing on the reduction of pork because that's where most processed meats are. So that's your bacon, your ham, and sausages. Whereas it's much less stringent for beef and lamb, for example. And importantly for climate change, there's a big difference between the emissions from pork and beef and lamb down to the different digestion systems that pigs have. So this is the ruminant versus non-ruminant consumption. And it's like about a quarter of the emissions from pigs. So it makes a really big difference there. So actually this policy, although we might think just reducing meat would be good for climate, it is, but not as good as if we focused on the ruminant livestock there. So this kind of shows a good example of how these impacts really need to be carefully considered when we're looking at any of these sorts of policy interventions. So I'm going to leave it there. So we've briefly just talked about how sociodemographics are a really useful tool for understanding these patterns of food consumption and vice versa, how the targeted policy interventions can be used by sociodemographics, by geography, or combine the two by geodemographics. Had a look at how the microsimulation can be a really good tool for summarizing some of this and understanding the fine scale variation, and looking at the policy interventions and some of the just a few examples there of the sort of range of the conflicts and the trade-offs of. So thank you very much for listening, and I think I'm going to hand over to Anne now.
Hello, thanks for that, Will. That was really interesting. I will share my slides now. Perfect. There we go. Okay. So my name is Onuselogu, and today I'll be presenting the process of evaluating strategies to promote healthier and more sustainable dietary choices, a project for my data science internship at LIDA and the University of Leeds. First, we can agree that what we eat affects our personal health, but that's also true on a larger scale. Because of what people eat or don't eat, nearly 1 billion people across the world are undernourished, and 2 billion people are micronutrient deficient. And in England, nearly 2/3 of adults who are more than 16 years old are living with overweight or obesity, and this is estimated to reduce life expectancy by 2.7 years, nearly 3 years on average. Furthermore, people in poorer areas are more likely to suffer from diet-related illnesses such as diabetes, cardiovascular disease, and tooth decay. However, what we eat affects the health of the planet too. For example, nearly 3/4 of the world's agricultural land is used to grow livestock that supplies less than 20% of the world's calories. 1/3 of human-made greenhouse gas emissions are caused by the food production in our food system, and that same global food system is responsible for 60% of global biodiversity loss. However, now you and I aren't the only people who know this. The IGD does too. But who are the IGD? Well, you might know if you listened to Judith Baxter's talk earlier. The IGD are the Institute of Grocery Distribution, a charity influencing the food and consumer goods industry, and their organization of social impact are the funders of this project. They are also conscious of the impact that consumers' dietary choices can have on their health as well as the planet. And they have also found that nearly 60% of people are thinking about or already changing their diets and want help to do so. Knowing that there is so much appetite for change, what have the IGD done about it? For one, they have established the IGD Healthy and Sustainable Diets Project Group, comprised of the IGD, the University of Leeds through LIDA, and various food industry stakeholders, who all have the common goal of encouraging healthier and more sustainable dietary choices. The methodology of this would include or involve retailers employing the behavior levers shown below, like signposting, placement, product influence incentivization, in various trials, then sharing consumer and transaction data that has been anonymized with LIDA so that LIDA can analyze the effects of the trials and determine whether or not they were successful. Shift to the Eat Well Guide would be used as a success metric. What is the Eat Well Guide? It's well known in nutrition and public health policy circles, but it is government guidance for, It is government guidance for a healthier and more sustainable diet. However, less than 1% of the UK population follow it fully, and if there was 100% adherence, it would decrease greenhouse gas emissions, land use, and water use of the UK basket, all while increasing the millions of years of healthy life in the UK in the tens of millions. So with the Eat Well Guide as a success metric, we can think of some potential research questions, for example, in the context of analyzing an incentivization trials data. Of course, there's the main question of whether or not the intervention moved consumers' baskets towards the Eat Well Guide, but we can also ask whether or not overall spend increased with the incentive or remained the same, whether or not engaging customers bought more fruit and veg, and if so, what types, and how often customers engaged in the first place, and this is among many other questions. With these questions in mind, I developed a generalized methodology to analyze data from an incentivization trial. It comes in two parts. First, the checks. Checking product weights, quantities, and nutrition info, making sure that we have everything we need and that there are no outliers. Also, determining the Eat Well segment of each product if it hasn't already been given. Then splitting the data that we have into pre, during, and post-trial time periods. And at the very least, we'd like to have at least a year of information from before the trial, and maybe even 2 years to account for COVID, and if possible, a year after the trial as well. Then, unless it's been provided, we would also determine the incentive engagement status of each transaction. After these checks, we could then perform analysis, including classification of customers by engagement frequency, investigating any overall shifts toward the Eat Well guide, and then observing any particular responses in different customer groups, either by frequency, age band, etc. In order to test these methods, I've used public groceries data from Kaggle, an online dataset sharing platform. This public dataset had about 4,000 customers and 40,000 rows, and the columns in gray here were provided, and the columns in green were either generated by me or, yes, mainly generated by me or recalculated. And with this data, we could have potential outputs that look like this, breaking down the baskets from the customers into pie charts that mimic the Eat Well guide. So you can see the ideal Eat Well guide breakdown is here in yellow. But with this consumer and public anonymized groceries data, we can see that this test consumer data has baskets that are just about a quarter fruit and veg and a quarter dairy and 10% protein. But then during the trial, this example data shows that there's been a doubling of the proportion of protein, yet also a reduction in the amount of discretionary foods that people were buying. Even though these methods are useful and generalized, there are still things to consider. It is applicable to future trial data, but still could be specified or expanded to explore changes in price or health ratings, or even focusing on different aspects of different trials using different levers or by different retailers. And also, with larger data sets, basket analysis might be quite insightful. So with the consumer data, since the baskets were quite small, it wasn't very insightful. Maybe a consumer would just buy one thing in a basket. And furthermore, with real transaction data, it may have missing values or category errors, which would necessitate those checks that I mentioned before, which I didn't need to do this time because I generated the data. And it could easily have millions or billions of products. And lastly, it's sensitive and would be need to stored and accessed securely. But since the code for my methods is generalized, it can be moved into secure research environments with the data there, and then the analysis could be performed in those environments. But however, moving back to the IGD project group, there are over 20 participating organizations, and therefore there are multiple trials ongoing with multiple food retailers. So this is very important. Trust, integrity, and confidentiality is key. That's why I can't reveal the results of any ongoing trials at the moment. However, partnership announcements and results are coming soon. That said, there is one particular partnership that's already in the public domain. So the partnership with Sainsbury's and the resulting, the analysis of the 60p fruit and veg trial that was run in 2020 and 2021. It used the incentivization, signposting, and placement levers. The trial was run in certain stores across England, and the results have been published by the IGD back in November last year. We saw an increase in the portions of promoted fruit and vegetables sold by 78% in January 28, 2020 and 54% in January 2021 compared to the baseline in 2019. And post-trial investigations are ongoing. Thank you very much for listening to my presentation. This is a slide acknowledging all the people who have helped to make this type of research possible, especially my supervisors, Michelle, William, and Ali. Thank you very much. Now, I will be passing the stage on to Vicki Jenneson.
Thank you very much, Anne. I will just share my slides for you now. So, hi everyone. My name is Vicki Jenneson, and I'm a public health nutritionist and research associate with the CDRC. And today I'm here to share with you some findings from the STRIDE study, which I conducted during my PhD research into the use of supermarket transaction records in dietary evaluation. So we all know that diet is a big deal for public health, and in the UK, a third of over 45s has diabetes or a heart condition. And each year, 8% of the total healthcare budget is spent on conditions related to high body mass index alone, and that's excluding the costs of diet-related conditions in the absence of obesity. So overall, poor diet is responsible for 1 in 7 deaths and a lot of avoidable disease. But we only know all of this because we've measured diets and disease rates in the population and observed the associations between them. So by assessing the diets of people in good health and comparing them with the diets of people in poor health, we can identify dietary factors and other modifiers of risk, which means we can identify groups of people at risk of poor health outcomes and hopefully design strategies to help them, be they targeted at the individual level or at the population level, such as changes to the food environment. But dietary assessment in itself has its challenges. We currently rely on self-report methods, which are subjective and known to underestimate dietary intake. And they're also highly burdensome for both participants and researchers, which makes them expensive to run. And as a result, we tend to compromise with small sample sizes and assessment at single time points in the case of cross-sectional studies, which means we're often lacking in the power to observe within population dietary differences. And these limitations on data capture also mean that metrics reported by different studies are inconsistent, resulting in a lack of comparability and difficulties drawing strong conclusions, even when the evidence is pulled together. And all of this translates to big challenges for the field of nutrition and human health research. And as the MRC sets out, there is a need for nutrition science to boost scientific rigor, rebuild public trust, break down disciplinary silos, and build industry partnerships. And this is all supported by the WHO and the UK Nutrition Research Partnership, who call for metrics which are objective, consistent, scalable, and offer temporal and spatial granularity, and are broad enough to answer a variety of different research questions. But to achieve this, nutritionists will clearly need to build capacity in data skills to allow technology to be harnessed for dietary assessment, such as the use of cameras, apps, or supermarket transaction records, which is my field. So my work considers what place supermarket transactions have in the dietary assessment picture. And in recognition that different metrics can tell us different things about the diets of our population and the individuals within it, I came up with the FED, the Framework for Evaluating Diet. And the FED depicts a flow of foods through different stages in the model, moderated by constraints such as price, personal preferences, values, behaviours, and all these things that make up consumer choice. So in essence, the FED is showing how foods flow from the supermarket shelves, restaurants and canteens, which make up our food environment, through to our shopping trolleys and the household level food purchases that we make, to our kitchen cupboards, where the food is available for us to eat, and supplemented by non-purchased food sources such as foods from our allotments, gifts from friends, or support from food banks, for example, through to the foods that make it to our plates and what we as individuals consume. And finally, to the nutrients in our bodies, where the nutrients may be absorbed and utilised or passed through as excretory products. So by depicting a flow of foods, the FED demonstrates how upstream interactions with our food environment influence our dietary behaviours and intake. And to date, dietary assessment has mainly focused on individual consumption and nutrient biomarkers. And while these are valuable indicators of an individual's nutritional status, they do face the problems of scale, as I mentioned earlier. So at the population level, I propose that capturing supermarket transaction records as a marker of diet gives us more scope to understand the drivers of dietary behaviours and an opportunity to influence them as well. So measuring diet at all stages of the fed is therefore valuable. And while data from a single supermarket captures only a proportion of an individual's diet, it has the potential as a useful dietary proxy at the population level. So I consider supermarket transactions to have three main benefits as a dietary proxy. Firstly, the data is collected continuously and automatically each time a customer shops and without their effort, which allows us to observe seasonal and longitudinal trends in population dietary patterns. Secondly, the transactions cover a large number of individuals, and linking loyalty card data to these transactions tells us something about the characteristics of the individuals in the sample and allows us to do subgroup analyses and identify dietary differences within the population. And thirdly, transactions are geocoded by their nature, so both at the store level and the customer area of residence, which means it's also possible to observe spatial dietary patterns which could inform local policy interventions. So, for example, in the map here, across the city of Leeds, we found higher levels of fruit and vegetable purchasing in the more affluent, suburban and rural areas to the north and east of the city, and lower levels of fruit and vegetable purchasing among customers living in deprived and ethnically diverse urban areas in the city centre and the southwest. But how well supermarket transaction records actually represent dietary intake will determine just how useful they are as a population dietary proxy. And so to answer this question, the STRIDE study compared supermarket transactions for a consenting sample of loyalty card customers with their self-reported intake captured by an online food frequency questionnaire, or FFQ. So the STRIDE study recruited nearly 1,800 loyalty card customers to one of 4 waves designed to account for seasonal variation in diet. And participants consented to complete this online food frequency questionnaire, capturing their dietary intake over the previous 3 months, and to share their food and beverage transactions data for 1 year prior to the study and 1 year during the study, which also covered that period of their FFQ as well. So now, as you can see in the table, just 688 of those customers were included in the analysis sample. So that's just under 40% of those who signed up, and that's due to poor completion rates for the FFQ, which further highlights to us the need for less burdensome dietary data collection methods. It's also important to note that our STRIDE participant sample was not particularly well representative of the general population. Participants were predominantly female, from an older age demographic, and of a white ethnic background. Most of them lived in areas within the top 50% least deprived and were relatively loyal to the retailer, reporting to do at least 60% of their food shopping with them. So now, to understand how well their purchases represented their dietary intake, I took daily nutrient intake estimates from the FFQ and compared them with daily purchase nutrient intakes estimates from transaction records generated by linking products to their back of pack nutritional information. And limits to agreements were quantified using the Bland-Altman technique across a range of absolute and energy adjusted nutrient metrics. But while the FFQ represents intake at the individual level, food purchases are captured at the household level. So I used some data collected from the baseline survey to account for the customer's household composition. So I took the number and ages of the other members of their household and used the UK daily calorie intake recommendations by age group to allocate those purchase nutrients proportionally between the different household members. So this created for us an individual level purchase proxy for each customer, which was designed to be more comparable with the intake measure than the household purchases measure alone. So let's have a look at the results. So here we can see how well absolute values for purchased energy compared with energy intake for the STRIDE participants. So without accounting for household composition, household purchases represent on average 2/3 of our participants' energy intake, suggesting that around 1/3 of their energy is coming from other sources, such as other retailers or the out-of-home sector. But we also see very wide limits of agreement here, which indicates that for some households, purchases account for as little as 5% of their total energy consumption. And in other households, energy purchased is up to 10 times higher than their calorie intake. So this is largely down to variability in household size and in loyalty to the retailer. So while on the face of it, household energy purchases appear to be a reasonable indicator of intake, when we look at the population average, this would appear to be the result of cancelling of opposing errors. So when we do account for household composition, agreement drops, and our individual level purchase proxy appears to represent around 1/3 of total energy intake across all customers. But as expected, agreement is higher for single person households, with purchases capturing just over 60% of energy intake on average. And we also see decreasing agreement with increasing household size, indicating there's a buildup of error that's coming from our individual proxy method. And finally, we find greater agreement with higher customer loyalty. So among those reporting to buy between 80 and 100% of all their food purchases at the retailer, which is the final row in the table, purchases represent on average 51% of energy intake across households of all sizes. But of course, we don't just purchase energy. Foods are made up of different nutrients, and the balance of those nutrients in our diets is important to our health. So when we compare the proportion of energy contributed by each nutrient from the purchase records and the self-report intake, agreement is much higher than we saw for absolute values, as a household size is no longer important here. So agreement is particularly strong for total fat and saturated fat, where mean values sit just under 100%, and we also see much narrower limits of agreement than we saw previously. But the lowest agreement is seen for sodium, which may be explained by foods from the out-of-home sector tending to be higher in salt content, or because table salt purchased at the supermarket is not purchased so regularly, so might not have been captured well by just 3 months of transaction records. So I think overall these findings are telling us that supermarket purchases represent dietary composition very well, regardless of household size and customer loyalty. So finally, in conclusion, the STRIDE study found dietary estimates from purchase data to be overall lower on average than intake estimates, reflecting a proportion of food sourced from elsewhere, as you would expect. We also found stronger agreement for single-person households, loyal customers, and particularly for energy, total fat, saturated fat, and energy-adjusted nutrient values, which is important for if we're planning to choose appropriate customer samples and also the nutrient metrics that this data can be used for. We therefore find that while purchases don't appear to be a good indicator of absolute nutrient intakes, they are a good proxy for dietary composition, which makes them potentially useful for spotting trends in dietary surveillance and ecological studies, and for identifying customers displaying different dietary patterns. For example, customers who might be following a high-fat diet, or customers with different levels of compliance with dietary guidance. These things could be really useful for identifying intervention target groups and monitoring how different policies affect different groups of customers. So that's it from me. It just leaves me to say thank you for listening. Happy to take any questions at the Q&A in the end. But first, I would like to introduce Jens, who will be giving the final talk.
Hello, everyone. Screen, a second. Okay, I hope you can share my screen. My internet connection isn't very good, so apologies if it doesn't go as for the other speakers. I'm not focusing on diet. I'm focusing on a different aspect of health, which is more about daily mobility and digital inclusion. And here the interest is in how digital inclusion can substitute or complement physical mobility, and what this means in terms of social participation. And by extension, health and well-being, but also what the role is of health in participation in the digital sphere and in physical mobility. And I'm doing parts of this work as part of a collaboration with others at Manly, at Leeds, and University of Manitoba as well. And I use data provided by the consumer data research. And the context really of this is the context of aging. So we all know that we are experiencing a demographic shift in society, and we see changes, of course. So that demographic shift is accompanied by changes in lifestyle practices, by diversification of lifestyle practices, of underlying subjective orientations, values, attitudes, but also ethnic composition. So as the society ages, the diversification of the aging segments is also continuing. And at the same time, we see profound changes of the transport system and the kind of digital landscape. And here the question is really what are the kinds of opportunities, but also the risks in the intersecting changes? Do changes in the transport system and the more digital-driven services and opportunities, do they lead to an increased social inclusion? If yes, so for whom, and particularly for more vulnerable and mobility-restricted groups? How has that changed during the pandemic? And do we see certain new kinds of vulnerabilities emerging? Are they amplified or attenuated during the pandemic? So these are sets of questions that link to the ways in which digital technologies are embedded in day-to-day lifestyles, and are very much being debated in the context of transport and social exclusion, and of course the digital divide in aging societies in particular. So the data sources that I am using, and colleagues, is first the two longitudinal data sets. One is the English Longitudinal Survey of Aging, and here we are focusing on people of age 55 plus, with about the sample of about 5,000 people. And a second one are concessionary smart card transactions from the West Midlands Combined Authority. And here we are focusing on people of age 66 plus who are eligible for free bus travel. And the sample is about 185,000 cardholders. And the reason why we are focusing on these two data sets are because they are longitudinal. It is possible to look at different trends and changes. ELSA focuses on the digital technologies, lifestyles more broadly, and of course we see what people are doing and in parts why. And Smart Cards, on the other hand, focuses on how people are traveling. So we have seen examples of that earlier in the TfL presentation, but here particular strength is that those Smart Card data are linked to demographics, age, gender, and ethnic group. So it allows us to look at changes in public transport use, and how, in particular, how that has changed during the pandemic. Now, these are kind of separate work streams. They're not connected at all, but they allow some form of informal triangulation and see what are the kinds of stories in terms of digital inclusion, physical mobility, their inequalities, and how they have evolved during the pandemic. So the first part of the study uses the survey data to develop a segmentation, and here the interest was on out-of-home activity. So a number of variables went into a cluster analysis that allowed us to identify different profiles of out-of-home participation, and we identified 6 out-of-home profiles or people with those profiles. And the first group shows an extensive participation across a range of different domains, such as participation in entertainment opportunities, eating out, meeting friends, volunteering, exercising, and traveling. That is, of course, just before the pandemic, 2018. We see variations of that. So another group is low out-of-home participation, and another group number 6, as well, low out-of-home participation, but a higher frequency of visiting friends, so domestic visits. And we can see that those different profiles are associated with different life situations. The variables pertaining to life situations were not part of the cluster analysis, but we can see different shares, different social class backgrounds as measured by occupational status and education. So we have those profiles, and then we looked at how they link to digital technology use. And previous research has found that digital technology use tend to be associated with higher levels of out-of-home activities, but there aren't actually that many studies about particularly that link. And what we can see here is the more clusters with more such activities to indeed use the internet much more often than people that show lower levels of activities, such as cluster 2 and 6. And also extends to access and use of smartphones, which vary quite significantly between more and less active clusters, such as 80% and 50% roughly is the kind of range here. We can also see if the internet is used, different activities take place. So more active groups tend to use the internet for information in communication, whereas other groups place a stronger emphasis on shopping, but also gaming. We found were some activities that in particular cluster 3 conducted. So we can see some variation here in terms of the types of activities that are undertaken using these technologies. We also see it across mode choice. Access to car is higher, as we would expect, for more active groups and lower for less active groups, but also public transport. So of course, as more out-of-home activities are conducted, the transport system is used in different ways, different levels. But what we can see here is also the of why public transport isn't used as much. And we can see that some, so the groups that tend to be more active emphasize issues of convenience and functionality versus for less active groups, we can see barriers related to health here different kinds of factors influencing mode choice. So how has that changed during the pandemic? Has now digital technology and the rollout across various domains contributed to greater participation of more excluded groups? And here we can see in this chart how different groups have changed their use of smartphones and of everyday internet. And you can see that there was a lower level at the beginning of the survey, of the first wave, which was around 2012, for the first wave that recorded internet use. And then we can see how some groups rapidly increased their daily internet use as well as smartphone use over time. And we can see that this also occurred for less active, more excluded groups, 2 and 6, but at a much slower pace. So we can see across the board an uptake of digital technology. The last wave here is during COVID and the COVID subwave. And you can see so that there is some catching up, but it isn't quite at the pace that would allow full catching up. And barriers to an uptake of digital technologies among those groups include in particular health-related barriers, but also lack to equipment, whereas also skills, of course, is an issue, but that is an issue across all groups. So we looked at the factors and in particular activities that influence internet use, and this is fully adjusted by sociodemographics and age. And we find that, a range of activities are associated with higher internet use, particularly those that linked to entertainment, eating out and traveling. Car access as well has relationships with most of those. So you can see here that in fact there's kind of a reinforcing relationship between physical mobility and digital inclusion rather than some kind of substitutive relationship. At least there is limited evidence of that. So the second part is about the smart card data. And here we were focusing more on physical mobility, and we were interested in what is going on during the pandemic. This chart shows ridership levels of older people in the West Midlands through 2019, which is the dashed line, and then through 2020. So you can see boarding levels and how it dropped during the first lockdown, here highlighted in red, and how it dropped again during the second lockdown. And the question is whether there are any kind of social patterns in this, as well as geographic patterns. And one thing we can see is that we can see different levels of people from different ethnic backgrounds in terms of how they return to public transport. The first chart shows boardings per persons before the lockdown, and we can already see that there are different levels of ridership among the white ethnic group, the black ethnic group here shown in blue, Asians, and so on. And we can see that the drop occurred across the board, but the recovery rates were much quicker for the black and mixed ethnic groups in particular, and much slower for the white group. We then used survival curves to estimate whether these differences are significant and estimate mean return rate, which is shown here. And the story here is that the ethnic inequalities persist in recovery rate pretty much throughout the entire time. And there's also a plateau in terms of return, or it seems to be a plateau in returning rates, and so that a full returning at the moment hasn't been observed, while the inequalities across modes seem to be amplified during the pandemic. Deprivation, which I would skip now in the interest of time, and we can also look in terms of where people live that tend to return earlier to the public transport systems, and we find that in particular in more accessible locations. So where level of services are better, return rates seem to be quicker as well. Now, deprivation is always a huge factor in these sorts of question is, if we control for deprivation, do these associations still exist? This is a hazard regression. The answer is yes. So we still see ethnic inequalities even if we control for deprivation, although it is just at the neighborhood level. But also public transport accessibility plays a role in helping people to return to the system, even if we control for other factors. So what can we draw? What conclusions can we draw from this type of work in terms of physical mobility, social participation, digital inclusion? So what we can see differential levels of out-of-home participation that is linked to and pretty much associated with different levels of technology use. Ill health is a significant barrier, and so seeing very limited evidence of a compensating or substituting of digital inclusion to physical mobility or digital technology use to physical mobility. What we instead find is that digital technologies tend to reinforce other forms of mobility. So people who are already very much participating out of home also tend to participate much more in a sense. So how has the COVID pandemic changed that? If anything, these patterns persist. And we can see that there is an unequal pace in which digital technologies are taken up during the pandemic. And we can also see a reinforced social selectivity across different modes.
Of ridership, and we can see that there's some increased forms of vulnerability are emerging here, where ridership levels are lower.
That has an impact on service levels, and people are already excluded, have few opportunities to participate. So what we here conclude is that it is really necessary to have concerted policy efforts to support at various points. So to help people engage with digital technologies that are at risk of exclusion, but also double efforts to bring white middle-class households back onto the public transport system in order to achieve goals in terms of sustainable and inclusive mobility. Thank you very much.
Brilliant. Well, many thanks to Will and Vicki and Jens for their fantastic talks. We now have about 5 minutes for questions to all of our speakers. And my colleague, Dr. Andy Newing, Associate Professor in Applied Spatial Analysis at the University of Leeds, is going to join me to co-chair this Q&A session, although I don't actually see him on screen quite yet. So we'll just make a start then. So there's a few questions in the chat. For those that we don't get through today, we'll ask just the speakers to reply to them in the chat. So if we start up then, this is a question from Fran Pontin for Will James. Given the discrepancy between health and sustainability policy you highlight, do you think there is capacity to develop a policy that simultaneously addresses health and sustainability goals, and how we go about achieving this from a data perspective?
Yeah, so there absolutely is, and the best example is probably the Eat Lancet, the planetary health diet recommendations that came out a few years ago. Obviously, the main issue is actually getting people to adopt these sorts of diets, and the more radical the changes are, the more difficult it's going to be. And yeah, the Eat Lancet one, that was very radical reductions in meat consumption, as would kind of be expected, really. In terms of from a data perspective, yeah, I think the National Diet and Nutrition Survey could be really useful for this, because one of the sort of future bits of work that we're just scoping out at the moment is sifting through the survey and finding individuals in there who already do conform to certain diets based on guidelines. So whether it's the Eat Lancet one or whether it's the NHS cancer guidelines or whatever, finding people who already conform to them, because then we know that is a realistic diet of someone with those socio-demographic characteristics that we can then apply to the population to see what the impacts will be. It's the main barrier is actually getting people to follow the guidelines.
Well, you've actually just segued into two other questions. So there's a question which I think is probably for Will, Vicki, and Dan to some extent about any ideas on what the barriers might be from your research. And that was from Jens. The barriers to a healthy diet. Let's ask Anne first then.
So at least in my research, one of the things that really has stood out is how the IGD has done these surveys asking people what the main barriers are for them, and cost is actually quite a big one. So yeah.
Is there anything that Vicki or Will want to add to that? That's great, thanks Anne.
I think just to reiterate the point about cost, really, we saw those spatial patterns in my map of showing differences in diet across the city. Part of that might be to do with cost. It might also be to do with accessibility and the types of stores that people have available to them as well, and the product ranges that are on shelves within those stores. So there's all sorts of different things that like retailers or the food industry could do to help people have a better diet in different groups in the population.
Thank you. And then I've got a quick question for Jens, and then we'll hand over to Andy for a final question. So in your talk, Jens, you had the two different data sources, the ELSA and then the kind of smart card stuff and bus ridership. Is there any way of combining those data sets?
Probably not to satisfactory level. So I tend to like to work with smart card data, but also complement or other kind of big data sources and complement it with surveys, just to see what the stories are, how consistent they are, because they can tell us different things and about different parts of everyday life that is really relevant. I think there is no way of directly combining the data sets in terms of, the sampling is very different. Of course, you've got sparse sampling in the region. This marker data set focuses on one particular region, so that is definitely a challenge. Methods of spatial microsimulation might help to estimate, for example, different lifestyle geographies at the small area level. So that is one some of the outputs of the research, of the analysis, perhaps contextualize them. But I think, yeah, a direct kind of matching is very difficult to do. Although we did experiment with it using the NTS, the National Travel Survey, and see how different travel patterns link to the travel patterns found in the NTS. But accuracy tends to be quite low. So, it is challenging, but it'd be beneficial if it was possible.
Brilliant. Thank you, Jens. Do you have any final question, Andy?
Sure. Thanks, Michelle. Yeah, this is spurred on by something that Anne said, but really this is an open question to the panel. And you mentioned the importance of sort of trust and integrity in this sort of research, particularly with working with the sorts of data sets that we've got. And obviously these data sets present huge opportunities, but what are the big challenges that perhaps the CDRC still needs to overcome to fully unlock the value of these data for the sorts of research perhaps that Vicki was talking about around being able to pool data from multiple retailers or multiple organizations? Does anyone want to jump in on that one?
I'll come in as you mentioned my name. So I think, so we saw small sample sizes in my study because people had to consent actively to participate in that study. So obviously that is a barrier. Consent is a barrier to sample sizes, but it's also important that consumers understand how their data is being used. So I think there's still a lot of work to be done in that area around understanding of data uses, and perhaps we can be slightly more clever in opt in and opt out for different uses of consumer data as well.
And really quickly to follow up on that then, Vicki, whose responsibility is it then to get the consumers on board? Is that the role of organisations like the CDRC? Those consumers have got a direct relationship with the retailer. Is it the retailers that need to be winning them over?
I think really it's everybody that's using data for any sort of purpose. I think the retailers have a more direct narrative perhaps with their customers, and they also have that due diligence around how their customer data is being used. But I think anybody working in this space and using data has a responsibility in that area as well.
Great, thank you. I could ask a lot more, but in the interest of time, I'll hand back to Michelle. Thank you.
Thanks, Andy. So we have just run over a little bit here. So perhaps if the speakers are kind enough to respond to the direct questions in the chat, that would be brilliant. And for everybody who's still with us in the session today, if you want to find out any more about any of these projects or explore ways you would like to work with the CDRC, please visit the CDRC website or get in touch via the info@cdrc.ac.uk email address, or alternatively, you can contact our speakers directly. All of this information will be shared in the after event email. So that just leaves me to once again thank all of our speakers, and if everybody could join me in a virtual clap. Thank you very much.